In this part of the lecture, we are going to explore the markers of tissue perfusion that we utilize in our clinical situations. First one that we are going to explore is the mixed venous and central venous oxygen saturation. So the idea behind mixed venous and central venous oxygen saturation is based on this very popular principle called Fick's principle. So Fick's principle is that the amount of oxygen that is consumed by our body is a product of the cardiac output and the difference in the content of oxygen at arterial and mixed venous levels, right? Therefore, if you want to know the oxygen extraction, which is the ratio of oxygen consumption and oxygen delivery, it is nothing but 1 minus the ratio of oxygen content in the mixed venous sample and the arterial sample. Eventually, we end up with the formula that our oxygen extraction ratio is 1 minus mixed venous oxygen saturation. Therefore, we can use mixed venous oxygen saturation as a surrogate of oxygen extractions. So, the initial part of shock, even though lactate has not started rising, there will be decrease in mixed venous oxygen saturation, which we have already discussed that it is an earlier marker of tissue hypoperfusion compared to lactate. Now, it is not always possible to sample mixed venous oxygen saturation by putting a pulmonary artery catheter. However, for all practical purposes, it has been seen that the central venous oxygen saturation trend correlates with the mixed venous oxygen saturation trend. So, in a normal individual, the central venous oxygen saturation is slightly more desaturated compared to the mixed venous oxygen saturation. Why? Because central venous oxygen saturation carries the venous return from the brain, which has a higher oxygen extraction compared to the rest of your body. However, during critical illness, the body tries to preserve the blood supply of the brain at the cost of blood supply of the viscera. So, therefore, the viscera have higher oxygen extraction compared to brain in a critically ill patient. In a critically ill patient, therefore, the mixed venous oxygen saturation is more desaturated compared to the central venous oxygen saturation. Add to it the increased myocardial oxygen demand, therefore, the myocardial venous return through the coronary sinuses, which is also a part of mixed venous oxygen saturation, makes it even more desaturated compared to the central venous oxygen saturation. However, if we see the trend, the mixed venous oxygen saturation trend coincides with the central venous oxygen saturation trend with a difference of roughly 5 to 8% between the two parameters. So, therefore, in clinical settings, we can use central venous oxygen saturation as a surrogate of mixed venous saturation, which is a surrogate of oxygen extraction ratio. Important thing that we need to realize is that if we have a low central venous or mixed venous oxygen saturation, it indicates that there is a mismatch between oxygen delivery and consumption. Therefore, the oxygen extraction ratio is high. So, this makes our job pretty simple, that we have to explore what is wrong with the patient and treat. However, a normal or a high central venous oxygen saturation does not guarantee that everything is alright, because in septic shock there can be microcirculatory shunting. So, what can happen is that a part of our cardiac output goes back into the venous side without offloading the oxygen to the tissues, or there can be mitochondrial dysfunction where the tissues are not being able to extract and utilize this oxygen. In both these scenarios, your central venous oxygen saturation is going to be higher than normal. However, that does not mean the patient is not dysoxic. So, in order to understand this, we have to look at other parameters also. So, the cautionary tale is that central venous oxygen saturation should not be used in isolation as a resuscitation target. So, very interesting observation was made in this study that in septic shock patient, the mean central venous oxygen saturation was 74%, and only 1% of these patients had low oxygen saturation of the central venous sample. So this means majority of them had normal or a high central venous oxygen saturation. So just looking at the central venous oxygen saturation does not give us a good picture. So coming to the next marker of tissue perfusion. So it is also a marker of anaerobic respiration, that is lactate. So lactate has been explored in the scientific community as a prognostic and therapeutic endpoint. So the initial lactate and the lactate clearance has been shown to correlate with mortality outcome. The problem with lactate again is that it can also be produced in aerobic circumstances when your glycolysis pathway is ramped up by the use of epinephrine or salbutamol or the body is in an inflammatory state, and it is not always due to increased anaerobic respiration. So how do we identify that? For that, there are two important parameters. One is the lactate pyruvate ratio, and the next is the surrogate of respiratory quotient that we are going to explore subsequently. The problem with lactate pyruvate ratio is that it is not available bedside, and we do not measure pyruvate in normal day-to-day clinical setting. So it is only of research interest. So we know that majority of the carbon dioxide that is produced in normal state is from aerobic respiration. So this follows a rule that around 0.6 to 1 mole of carbon dioxide is generated per mole of oxygen utilized in aerobic respiration. So this is something that we know as respiratory quotient. So the normal oxygen utilization in our body is around 250 milliliter per minute, and the carbon dioxide production is around 200 milliliter per minute. So roughly the respiratory quotient is around 0.8. So the respiratory quotient in a normal state also can vary slightly based on the diet that you are taking. If you take a very high carbohydrate diet, then respiratory quotient increases. However, a normal aerobic respiration is unable to generate carbon dioxide more than the oxygen that it uses. So therefore, the carbon dioxide difference in the carbon dioxide content in the veno-arterial difference and the veno-arterial difference in the oxygen content ratio should not be more than 1. In a dysoxic tissue, what happens? The cells release, the mitochondria release more and more protons, acids into the cytoplasms, and which are buffered by the bicarbonate. So once bicarbonate buffers this proton to form carbonic acid, it dissociates to release more carbon dioxide. So when the cell is resorting to anaerobic respiration, the protons that are released are buffered by bicarbonate to produce carbon dioxide. So in one hand you see that the VO2 is coming down because cells are not getting oxygen and it is resorting to anaerobic respiration. The VCO2 does not come down that much because there is an anaerobic source of carbon dioxide generation. Therefore the ratio now is altered and it is more than 1. So in clinical practice, we usually do not calculate the content of carbon dioxide, but if we go through the carbon dioxide dissociation curve, you can see within the physiological limits, the partial pressure of carbon dioxide is approximately proportional to the carbon dioxide content in the blood. Therefore, we can use the partial pressure difference of carbon dioxide as a surrogate of content difference. In clinical scenarios, the PVA-CO2 gap and the CaVO2 difference ratio more than 1.4 signifies anaerobic respiration in our body. One of the beautiful thing about this parameter is that it reacts faster than lactate. So at the onset of anaerobic respiration, your lactate levels may be normal, however you are going to get an altered gap ratio. PVA-CO2 gap in isolation has another very beautiful function. In order to understand this, we have to go through this physiological rational. So imagine a normal microcirculation which has a good microcirculatory flow and it is homogeneously perfused. So there what happens, there is no build-up of carbon dioxide, because carbon dioxide is usually very soluble in blood. So the tissues do not end up with lots of carbon dioxide build-up, as it is washed away very efficiently. Therefore, the tissue carbon dioxide partial pressure, which is roughly equal to the venous partial pressure carbon dioxide, is not very high. And the difference between the veno-arterial partial pressure of carbon dioxide is not more than 6. However, if you have a stagnancy in the flow at microcirculatory level, or there is an inhomogeneous flow at microcirculatory level, the carbon dioxide in the tissues build up and more carbon dioxide gets offloaded into the circulation, thereby inflating the veno-arterial carbon dioxide gap. So the veno-arterial carbon dioxide gap more than 6 signifies stagnancy in the microcirculation. So this stagnancy can be because of a global decrease in cardiac output, or it can be because of microcirculatory dysfunction. It is very important to realize that PCVA CO2 gap in itself is not a marker of tissue perfusion. No, it is not a marker of tissue perfusion. It is a marker of adequacy of tissue flow. Okay. There are other clinical markers as well, which are very important because of the latest Andromeda shock trial that has been published, which has shown us that a capillary refill time guided therapy is as good as lactate guided therapy. Another important parameter that we keep watching in our clinical practice is the mottling score. So the mottling score is something which is also a marker of tissue perfusion. There are some other techniques by which we can image the microcirculation under our dorsum of our tongue by doing a orthogonal polar spectrometry and all those things to see in real time what is the percentage of perfused vessels. However, we do not see this in our day-to-day clinical practice, so I will not be exploring that in much detail. I will conclude with this important flowchart, which sums up how we should use our tissue perfusion markers. So the idea behind resuscitating a patient is to keep the lactate concentration below 2. So if the lactate is less than 2, we can be pretty much sure that the anaerobic metabolism is being reduced. And also the fact that good lactate clearance has been shown to correlate with improved outcome. So this becomes a very important target. However, it should not stop at that level. So if your lactate is normal, you can still have a mismatch between your delivery and consumption, which can be picked up by a low central venous oxygen saturation. So if the low oxygen saturation in the central vein is low, that means your oxygen delivery is inadequate. So what determines delivery? It can be your oxygen content or your cardiac outputs. So you can ramp up the cardiac output by seeing the fluid responsiveness and trying to increase the cardiac output. Or if your patient is anemic, you may have to increase the hemoglobin level. Or if the patient is hypoxemic, you have to give some respiratory support. If central venous oxygen saturation is normal or high, we have understood that we can still have some problems going on that cannot be picked up by the central venous oxygen saturation. It can be microcirculatory dysfunction, or it can be tissue dysauxia at subcellular level, which can be picked up by the PVA-CO2 gap and the PVA-CO2 and CAV oxygen gap ratio. So they can pick these problems up and for you to take subsequent measures. Thank you.